Thank you. Good morning, Dr. Varun, Dr. Shantaram, and all my respected colleagues and friends. Thank you to Dr. Vijayakumar for inviting me here to talk about the role of bariatric surgery. I think we've taken a whole journey across the spectrum of diabetes management, starting with Dr. Madhavan's excellent talk on sulfonylurea, metformin, and what we use all through in our daily practice. You've had a bird's eye view about all of it. So these are some of the questions that I shall try and answer. What is the rate of remission in terms of diabetes and metabolic syndrome with bariatric surgery? I think what is of more important to us as clinicians is how long does the remission last, and does it impact upon the type of surgery? And I'll talk about what it is. Does it impact on the outcome, and is it just the weight loss alone? And what are the pathophysiological mechanisms behind diabetes remission? And how do we attain this fine balance between hyper and hypoglycemia, which is one of the complications of bariatric surgery? Currently, the most common procedures that are done for bariatric surgery are these two: the Roux-en-Y gastric bypass and the vertical sleeve gastrectomy. These two are not done as often, pretty much out of favor. Only these two remain, and if you read all the more recent articles, they've been talking about these two only mainly. And basically, both of them involve some restriction of the stomach volume and a rapid delivery of undigested nutrients to the proximal part of the small intestine. So bypassing the the digestive area in the stomach. So that is the basic principle behind both of these surgeries. This is a snapshot of the amount of weight reduction that occurs. So it's about the middle two columns, the Roux-en-Y and the sleeve gastrectomy. You can see that there's about a 60% weight reduction and somewhere between 60 to 80% of diabetes remission. Mortality rate, I'll talk about it. It's roughly about somewhere between 1 to 3 in 1,000 in the immediate short term after a bariatric surgery. And obviously we need to keep this in mind when we think about recommending it for people. So talking about the mechanisms behind the remission, I put it as pathophysiological mechanisms because obviously we're altering our normal physiology to some extent, but you can think about it in four there are many reasons why blood sugars improve and weight loss occurs after a bariatric surgery. These are some of the more simpler hormonal shifts. I don't want to go into great detail, but one of the most important ones is that there is an increase in the postprandial GLP-1. Dr. Athar Asirvadam gave a wonderful lecture on the GLP, on the incretins, and one of the things that happens with bariatric, because you're delivering the undigested nutrients to the more proximal part, is that you have an increased postprandial, particularly GLP-1. GIP, it seems to be all over the place. Some studies show no change, some studies show increase, some studies show a decrease actually. Ghrelin decreases. Anytime we reduce the volume of the stomach, you're going to reduce the ghrelin secretion. So most of them show a reduction in fasting, and some of them show a reduction in postprandial ghrelin. And this is probably one of the ways that appetite reduction occurs after bariatric surgery. Glucagon is also reduced. We heard about the triple agonist in the previous talk. Glucagon levels are also reduced after bariatric. These are the main hormonal changes that occurs after most bariatric surgeries. Of course, the tissue changes because of this are an improvement in the insulin resistance at the level of the liver. In the immediate post-op period itself, you have a 30 to 40% increase, which is why the glycemic control improves almost immediately, even before the weight reduction occurs. We know that. So there is a significant improvement almost immediately in the liver insulin resistance. And of course, in the long term, there would be a reduction in the hepatic and the pancreatic ectopic fat that we've talked about earlier. There is a reduction in all of the inflammatory markers, but I just pulled out 2 or 3 which are more potent markers of insulin resistance. So for example, the STRAP protein, which is an enzyme found in macrophages and dendritic cells, which is a marker of insulin resistance, is reduced. And then the microRNAs, we keep talking about it because they're now becoming therapeutic entities in other situations. So this particular microRNA, which propagates a pathway that increases the lipoapoptosis of pancreatic beta cells, which ultimately causes insulin deficiency. This microRNA levels reduce, which means there is preservation of the beta cells after bariatric surgery. Again, another microRNA which increases insulin resistance through other intracellular mechanisms also reduces after bariatric surgery. So this is one other potential pathway. there is a change in the microbiome. So what happens in obesity is there is a reduction in the gut diversity. And because of this, there is a chronic low-grade inflammatory state that is induced in obesity, probably because of more gram-negative bacteria, which increases the level of the plasma lipopolysaccharide. And there is more levels of the plasma LPS, and there is also more translocation from the gut to the blood because of altered gut-blood barrier. These are the things that happen in obesity. And after bariatric surgery, it has been found that the gut diversity goes back closer to normal, and that there is a reduction in the LPS and LPS binding protein. So there is some change in our microbiome which also occurs after bariatric surgery. There is also changes in the bile acid dynamics, which induce alterations in the glucose metabolism. I'm not going to go into detail, except to point out that there are changes in the levels of the FGF19, which in the long term increases glycogen synthesis, reduces gluconeogenesis, but mainly helps to reduce food intake. So these are some of the pathophysiological mechanisms by which bariatric surgery improves diabetes. So the blood sugar reduction occurs both by weight loss dependent mechanisms, which are sort of more the peripheral mechanisms, so improved whole body insulin sensitivity, reduction in hepatic fat and fibrosis, so reversal of fatty liver is very common with bariatric. And then there are weight loss independent mechanisms which we tend to see more early. So improvement, for example, in the glucose and insulin dynamics. I talked about the bile acids, the postprandial gut peptides, improvement in the adipose tissue insulin sensitivity so that the free fatty acid levels come down. So there are both weight loss dependent and independent mechanisms after the two mainly performed bariatric procedures. I'm sorry, I don't know why this thing is not projecting properly. Something has happened. But this is the timeline of the physiological changes after bariatric surgery. In the early post-op recovery period, we mainly see the changes in the gastrointestinal peptides. In the period of rapid weight loss, which we would normally see in the first 3 to 6 months after the bariatric surgery, there is an improvement in the skeletal muscle insulin sensitivity and the adipose insulin sensitivity. Thereafter, the weight loss reduces, but here also the blood sugar control continues because of changes in the bile acid circulation and progressive increase in the FGF19. And weight loss maintenance is where we land up seeing complications, which I'll talk a little bit about. What about mortality? Always we are worried when we send people, particularly people who have a high BMI, when we send them for a bariatric surgery. In this particular sort of analysis, they found that 3 out of 392 people died of complications of the bariatric surgery in the diabetic group as compared to 4 out of 1,609 in the non-diabetic group. In other words, it seems that the literature says that people who have diabetes who are undergoing bariatric surgery may be at risk for higher mortality. It depends obviously on their comorbid conditions, but this is something we need to keep in mind before we recommend bariatric surgery. However, after that first period of complications from bariatric surgery, long term, if you see, this is from there is a study, a Scandinavian outcome study, which is quite often quoted. What it showed was that in the long term, life expectancy improved by 2 years in the diabetic versus the non-diabetic population in the group that underwent bariatric surgery as compared to the control. So immediate we need to keep in mind, but long-term mortality is reduced. So this meta-analysis showed that short-term all-cause mortality was roughly around 0.18%. It seems to be higher for open surgeries and lesser for what are called primarily restrictive surgeries. Long-term mortality, however, similar numbers, a reduction of about 41% in all-cause mortality. So these are sort of big data analysis sets. I think the most important question, like I said in the beginning, apart from the mortality during surgery, is what is the rate of remission? How long do they remain without diabetes? So in this, they looked at 12 RCTs, and they looked at 846 people who had undergone bariatric and 662 who had usual care. And in this, 421 people, nearly 50% of people, more than 50% in the bariatric surgery group achieved remission. Remission was defined either by a HbA1c of less than 6 or 6.5 without medications versus 193 in the usual care group. In general, what they saw was that younger patients who had higher HbA1c and who were more likely to be on insulin were the people who underwent bariatric surgery to begin with. But there was no difference between the remission rates based on duration of diabetes or the pre-existing BMI. So we don't need to restrict based on duration of diabetes or BMI. Interestingly, this meta-analysis also found that intensive insulin therapy induced remission in 50% of patients at 1 year, irrespective of the BMI. We all know about using insulin early on, but this meta-analysis clearly proved that it is also, at least in the short term, it induces remission. SGLT2 inhibitors and GLP-1 analogs also induce remission, particularly more when combined with insulin. Relapse rates. Though we know remission is good, the relapse rate is about 50%. This is at the end of about maximum of 10 years of follow-up. 50% in the bariatric surgery group, but 90% in the usual care group. So people who were initially achieved remission, let's say with insulin or GLP-1 or SGLT2, 90% of them relapsed, and they could not sustain without needing medications at the end of 10 years of follow-up, whereas 50% in the bariatric surgery group did relapse, but 50% remained diabetic free. So these are the currently known rates. One of the other sort of complications that we come across is the postprandial hypoglycemia that occurs after bariatric surgery, and this occurs because of this rapid delivery of nutrients to the foregut. So there is a increased postprandial GLP-1, and this occurs both by insulin dependent and insulin independent mechanisms. The insulin dependent mechanisms are partly because of reduced clearance of insulin, and the hypoglycemia does not suppress the insulin secretion enough. So there is sort of a delinking of the beta cell responsiveness to the glucose fluctuations. And there are the bile acid pathway that I spoke about earlier, changes in the microbiome. Both of this seem to increase the risk for post-bariatric hypo. The post-bariatric hypo tends to, the very severe requiring hospitalization, which we very rarely see, occurs in less than 1%. The ones which are mild, self-reported, seen on a glucose monitoring, are as much as 30 to 50%. The risk factors for post-bariatric hypoglycemia include the female sex, absence of preoperative diabetes, so people who are normoglycemic before bariatric, large post-operative weight loss, so sudden weight loss immediately 3 to 6 months after the bariatric, usage of antidepressants, SSRIs, SNRIs, Roux-en-Y, because you have a much more bypass and more sort of malnutrition compared to a vertical sleeve gastrectomy, history of prior cholecystectomy, and a history of symptoms potentially related to hypoglycemia even prior to surgery. So these are the ones that seem to increase the risk for post-bariatric hypoglycemia. So to sort of summarize, the positive findings about bariatric surgery in diabetes is that it is definitely a therapeutic tool with reversal of comorbidities and its complications. I didn't talk about it, but studies have shown that it reverses albuminuria, reverses hypertension, and there is lower progression of retinopathy. However, the 50% relapse rate or the failure to reverse in some people, we don't need to keep it in mind. And then there are other complications related to the surgery itself, like bleeding, stomal stenosis, vomiting, reflux, and of course the post-bariatric hypoglycemia that I spoke about. What do the guidelines suggest? So this is the ADA 2024 and their recommendations for metabolic surgery. They say we can consider it as a weight and glycemic management approach in people with diabetes with a BMI of over 30. For Asian Americans, they recommend 27.5, who are otherwise good surgical candidates. It should be performed in high volume centers with teams who are knowledgeable and experienced in managing this. And people being considered for metabolic surgery should be evaluated for comorbid psychological conditions. Sometimes we find the surgery being done in people who have depression or other psychological comorbidities, which I don't think is the appropriate situation to do the surgery, or other social and situational circumstances that have the potential to interfere with surgery outcome, and they should remain under long-term medical and behavioral follow-up and treatment. These are the guidelines for bariatric surgery from the Indian group. They came out with these guidelines a couple of years ago, and they recommend bariatric surgery again for a BMI of about 27 if there are coexisting comorbidities, including diabetes. So that is considered a comorbidity. So to finish, bariatric surgery is currently a good option for remission of diabetes. Certainly it seems to be achieved in about 50% of people. If you look at the numbers, but I think what is very important is to look at the center where the operation is taking place and also assess the preoperative status carefully, particularly the mental health. And we need to have a pragmatic and realistic understanding of the risks and benefits. the need for continued care with lifestyle and follow-up. Now we are seeing people 10 years out who have gone back to their original weight because they are not able to maintain that level of diet and exercise, and the relapse rates that occur therefore after 8 to 10 years also we need to keep it in mind. And that's, yeah, thank you very much.